Scalpel? Check. Hammer? Check. Vibes? Always sterile. Welcome to Scrub. All right, welcome everyone to Scrubbed Podcast, episode 5. Believe it or not, we are still going stronger than ever with guests who continue to amaze us. As a reminder, Scrubbed is an invite-only podcast where we explore deeply behind orthopedic surgeons as they have ascended to the highest levels, and to learn more about them specifically, not just necessarily what's on their CVs, but more about the character that forms the person. And today, in amazing fashion, we have the wonderful Dr. Paul Tornetta, who is widely considered in orthopedics the orthopedic trauma specialist. He has published countless numbers of papers. He is been head of the OTA as well as the American Academy of Orthopedic Surgery. He is currently the head at orthopedic surgery in the Trauma Fellowship at the Boston Medical Center, and excited to have him on the show. So welcome, Dr. Paul Tornetta.
Oh, thanks very much, Steve. Nice to be here.
Absolutely. All right, so we're going to hop right into it, Dr. Tornetta, since I saw your Dunkin' Donuts cup and it made me reminiscent of my time spent in New England. So you're from New York, is it? I want to hear, if you don't mind, a little bit about your childhood and your upbringing.
Yeah, sure. So I grew up in sort of middle class, suburban, 30 miles north of New York City area. I'm a single child for my parents. I have a half sister. My mom was, a mom and did some real estate and some consulting and things like that. Very bright woman. Had not gone to college. My dad was a salesman and was in publishing. He could literally sell anything to anybody. Maybe not the best quality, actually. I had a sort of normal upbringing in a public school background. And I learned a lot of lessons in my childhood, primarily from my mom, who really I owe everything I've accomplished to. She was always of the mantra that, like, there's no bad questions. So that was something that I had from the time I was very, very young, was that I was allowed to ask anything. Didn't matter what it was. I could literally ask, and I would always get an answer. And I think when I was about 5 or 6, I started asking a lot of questions and didn't understand the answers. And I also, when I was really young, I actually had heart surgery when I was 4. And that sort of pointed me in the direction of medicine, which I think my mom was happy about. So she fostered that along my growth. Normal kid stuff. I don't think there was anything too exciting about my upbringing. My mom was great. My dad was sort of a salesman.
So do you mind sharing, like, what kind of heart surgery did you have? And do you remember anything about that experience?
Yeah, I had a patent ductus. So, 15 years after that, you would just give someone aspirin and it would solve the problem. But back then they split your chest open. So I've got a nice big thoracotomy scar, and it actually dehisced. So I remember being in the hospital, getting like daily dressing changes is kind of one of my earlier memories. I don't really remember anything leading up to it. I just kind of remember that part of it, but resolved well. And, no untoward effects. Once that thing's closed, it's, you basically have normal anatomy.
So that's that's very fascinating. I mean, most boys in particular, I've found, don't really have memories at 4 years old. So I have to imagine that was, I don't want to say traumatic, but at least kind of memorable enough that it changed your trajectory.
Yeah, it certainly was impactful. I apparently, not to my remembrance, but apparently I got to know the doctors pretty well. I was interested in a lot of things. And then I decided, I'd be a heart surgeon. And when I was 5 years old, my mom got me a stethoscope for Christmas. A little subtle introduction to maybe a good direction in life. I don't know. And and then from there, really through school, I was, sort of a student athlete like most of us were. And but I excelled in sciences more than the liberal arts stuff, and then it sort of just fit with medicine well. So that was the trajectory I chose.
So what was mom like? Was she someone who was readily available at sports? Was she, talk to me a little bit more about that relationship, because it sounds like she really was a big impact.
Yeah, she was. I mean, she is, she was one of the smartest people I met, but she had a tough childhood that I won't go into, but based on that, she really worked very hard to make my childhood a good one. And it was, so she was around. I mean, she worked, throughout my childhood, but she was always there. And, she was really, I think, a central focal point for me in terms of stability in life at that age.
Yeah. Yeah, I think that concept is fascinating, right? Because each generation we kind of have an opportunity, right, to see the things that we grew up with, to maybe change or tweak the things that we grew up with. Like, is there anything that you find yourself doing in adulthood that's maybe kind of a direct result of the way that, you were raised?
Yeah, I think that from my mom who had some, she had some health problems too, but I feel like everything I learned around being a good person, around empathy, you know, seeing multiple sides of an issue, all came from the way that she thought and carried out her life. Those are gifts I think you get from someone modeling them well. And I think that extends into professionalism as an adult, right? So, as a resident, we all did this, right? We were residents. We look to those who we respected to model the behavior and the activities that were important. So if you respected someone and one of the things they did was, spend a lot of time talking to their patient in clinic, you automatically thought that was a good thing to do. If you didn't respect someone and they did something, you would think it's a bad thing to do. So I think that, most of what we learn at a younger age is from modeling. And I think that persists in a professional and, environment still. Right. Like I think now I look at, I know Roy tapped me to be on this, and Roy is one of my mentors. I'm sure we'll talk about him later. But when I was learning things and growing up, I never trained with Roy, but he was one of those people who I looked at when they're on the podium or whatever and thought to myself, well, I should do that because look what he's doing, right? I respect this guy, and that's a good thing. So I think that everything is the same. You develop as a child based on modeling, you develop as a professional based on modeling, and you continue to develop as an adult based on modeling. So I think all of these things are completely intertwined.
Dr. Sanders has a tremendous number of positive things to say about you. It's obvious why, but I want to hear it from the other direction. Like, let's unpack it a little bit because when you say, "Hey, I watch him and I want to model those things," what is it about a man like Roy Sanders that just inherently speaks to I need to model that?
Well, I think there's a lot of things. So, my interaction with Roy began early. So when I trained at Downstate, and I was a nobody from a no place. And Roy was a nobody from a no place, when he was going through. And when I first met him, I was just incredibly impressed with, the basic knowledge and really the intricate specific details around how he was doing what he was doing with care. And I think that that's the thing that is most notable to me about Roy. He has a lot of incredibly strong qualities that you would want to model. He's an outstanding business guy. He's a good politician. He's really there's not a lot he's not really one of the best at. But the thing that really hooked me about it was, I wanted to be great for my patients, and I felt like he was great for his patients. And that's the kind of thing that I think hopefully my residents take from me to say, hey, he really wants to be great. This is what it takes. Um, and then I'll tell you sort of the first interaction was, I didn't get a good trauma fellowship. I guess we can talk about that. But the first time I met Roy, to stick back with Roy, first time I really had a good interaction with him is that I got asked to do a chapter when I was very young in practice. Like I think it was maybe my second year in practice. I don't even think I was an academy fellow yet. I think I was still like a candidate member. And I got asked to do this chapter in OKU trauma. And back in those days, there wasn't virtual meetings, there wasn't, editorial manager, there was, paper that you mail back and forth that you had typed, right? So the academy, which is incredibly strong in education and still is, flew everybody in who was doing OKU trauma for that like lower extremity section. And we all sat around, we all got everybody else's manuscript, and we all sat around the big boardroom table and hashed out like, well, I think this edit should be made. I think that edit should be made. And this is just to speak to the kind of person that Roy is, right? So Roy was talking about something. I completely disagreed. And of course, I was a bit of a hothead back then. I said, well, you know, why does that matter? And then I went off on a tirade about why it didn't matter. And he kind of looked at me, wait a second. He goes, that's a good point. So, as accomplished and bright and talented as Roy was, he still maintains to this day an open mind for discussion. And, that I think he looked at me and said, I don't know who this young guy is. I think he had also given me my board exam, which is a whole nother story. But um, by that time I had already met him. But to see someone who's very accomplished, who's at the top of the field, who's willing to listen to someone younger with less experience because they have an opinion is something I've never lost either. I hope. Like I tell my residents, look, if you see something I'm doing that's stupid, you got to tell me, right? Like everybody in the OR should be free to tell me when they can see something better. That environment in the operating room, in clinic, even, in morning conference, that environment of being open-minded, giving everybody the benefit of the doubt, to speak freely and to, as my mom said, like there's no bad questions. So I encourage that. And there's nothing more fun for me, honestly, than when my residents challenge me. Because either I learn something or they do, but it's a positive experience for everybody. And I think I got that from my mom and from Roy equally.
Yeah. Yeah, I kind of have chills as you kind of talk about that quote from your mom, right? There's no bad questions. I think honestly, getting into the habit of saying I know everything is probably the biggest mistake that high level achieving people make, because what happens, right, when you say there's nothing left to learn?
Yeah, so I've always looked at it the opposite, and I give some graduation speeches and invited lectureships, and the talk I always give it's called question everything. And that has been the mantra of my existence in orthopedics is that, and I would agree with you, Steve, that the more the less you know. So like as you gain more and more knowledge, you just have more and more questions and we don't have all the answers. And there are some revolutionary changes that occur out of common sense. A
Yeah.
lot of the things that I have done and directions I've gone in my career because I actually didn't have any mentorship early on in my own hospital. So I made up because it made sense. And then, we tested it and it worked. But, this is the way that humans investigate and try to answer questions. And in the same way, when there's something that's good where you actually have data and you have an answer, to change should be a really high threshold.
Yeah.
So the area, of exploration is always the area where we don't have a great answer. Someone
Yeah.
says, well, intramedullary narrowing of the femur is okay, but I want you to try this brand new thing. Well, you're going to have a pretty high threshold and pretty good evidence to make me change from that method. But when you were
Yeah.
doing roller traction, putting a nail in seemed like a pretty good idea.
Yeah, I mean, I'd love to go down the rabbit hole of orthopedics with you. I want to explore more about your life. But the reality is because of that very question, I mean, I've changed things in my practice even. I mean, MRI findings of femoral neck fractures when we get a CT scan and we assume that it's okay. I mean, the reality is as technology advances and if we're not at least challenging our brains to think that, hey, with new technology, there are new answers and we need to reflect that. But one thing I really want to bring up because it was profound when you said it is that what drives me is patient care. My goal is to learn from others who are great because that will allow me to be great for my patients. So, one thing I'm picking up on a little bit, I'm hoping you can explore is you kind of mentioned it briefly of a middle class upbringing. You seem to be the type of person who, despite being a prolific orthopedic surgeon, probably relates a lot more to their patients than one might think. Do you think it was that upbringing, and what was it about that that really helps you relate?
Yeah, I think every surgeon with empathy can relate to their patients. I do think there is maybe an advantage of not growing up wealthy, right? In terms of understanding what people are going through, though I think it's just an advantage early on. I think as people experience interaction with patients over years, and you see thousands and thousands of people, I think everybody gets to the same spot. But yeah, I mean, I worked every summer. I was a loan and scholarship kid through college. went to the cheapest medical school I got into because finances mattered for me. So yeah, I mean, it wasn't necessarily an easy road, and frankly, the question everything mantra was fantastic as a child. It wasn't bad in high school. In college, it wasn't so appreciated by everybody, and I certainly wasn't appreciated in my medical school interviews where I didn't do so well there. So I didn't get into a lot of schools, but you don't need to get into too many as long as you can afford one of them. So I went to a state school.
Do you ever find it ironic that that same mentality of challenge everything or go against the grain, I guess I'll say it that way, has helped you to be who you are, who is someone who has added more to the body of orthopedic literature than arguably any other orthopedic surgeon in the country that was shunned when you were coming through training, it sounds like.
Yeah, it wasn't. Well, first off, I don't think that the second statement is true. I think there's a lot of people who have done a lot, and I don't think any of us do anything sort of independently, right? Everything is a group effort, and everything plays off something else. So, I can't imagine how many times did I do a study based on something I learned from somebody else. I have no idea, right? And I'm sure there are people who do studies based on something I said somewhere at some time that was a clinical observation. So I think, as a field, we grow together and head in a direction together, right? And we're doing that better now than we ever did with larger scale trials and big questions. But we can't leave behind the small technical issues either. But yeah, I would say, when I was a resident, I had my share of colorful challenges, let's just say. I got thrown out of one hospital for basically they tried to have me fired at the VA hospital because I was pretty knowledgeable and I was really there all the time and I did stuff and I insulted a lot of people because I was very direct. So they wrote like this huge letter to my chair saying, that I was irresponsible and that I couldn't come back to to the hospital. So I took this, and this was to the guy who was basically hiring me already for, to come back. And he knew I was good at what I did, but he also knew I didn't really take a lot from anybody even then. So it's kind of a funny story. So he handed me the letter that was signed by like 13 emergency room physicians that, I was irresponsible, et cetera, which I knew was forced from one person who I had insulted, who was the chair of emergency medicine at the time. So he gave it to me. My chair was named Stan Gordon, and he was a wonderful guy. I'll give you his quote that I learned from, which is good for everybody, which is when you're trying to assess someone's behavior, always consider their motivation. It's a
Phenomenal.
critical thing to understand, and that comes to patient care too. So he said, Paul, I just go fix this. And he handed me the letter, right? So I went to the VA and I went to each of the people who signed it. And I said, hey, good to see you. Just quick question. Like, have I ever not answered your page? Have I ever not done something right for a patient? Like, no, no, no. I said, well, why did you sign this? And I made them each cross off their name, all of them. And then went into the person who had organized the whole thing. And I, went in and I said, can I meet with you? Yes. Okay. So I went in and I met. It was a woman who had been out of medicine for quite a while. She's actually not very good at what she did. And I had insulted her by essentially telling her that. So I said, I understand that that you wrote a letter to my chair. And she thought I was like, in Schitt's Creek, which I was not, because I had the letter with all of it crossed off in my pocket. And I said, so just so you know, what you did was dishonest. And everybody in the ER knows that. They've all rescinded their signatures. I'll be back and I'll be watching. And I left. And, so I had some issues as a resident. I was pretty aggressive, but I would say always on the face of what's right for patients, right?
Yeah. Yeah.
And in those days, it was a battle. It was a flat out battle sometimes to get the right thing done, especially in a resource poor environment. I mean, I took with one of my colleagues when I was a first and second year resident, we went around the hospital taking our own x-rays and doing our own EKGs because, there weren't staff to do those things. Or if they were going to do them, it was going to take forever. So we learned how to use the portable x-ray machine and, did those things. So it was a different environment than what happens today. But in the same way, it's always about what's right for the patient. And if you do that, every time, you'll have a wonderful career.
Yeah, absolutely. I mean, and to set the stage for the listeners, I mean, working in the hospital, working in orthopedic surgery, I mean, it's a pressure cooker, especially in the operating room where seconds or fraction of a second are relevant. I think as surgeons, we oftentimes get mislabeled as being overly direct or quote unquote overly passionate. And I don't really, for us, you ask us why, I think we would say it's not an emotional thing. I'm not looking to hurt your feelings. I'm looking to go from A to Z as quickly as possible in the name of the patient. So, what I'm interested to hear from you is because I think we've all related to being that passionate. Well, every good surgeon has related to being that young, passionate resident. Has that changed over your career? Has it changed over the way that you've interacted with nurses, with trainees, fellows? Is there a certain methodology of success?
Yeah, I think that first you always have to listen, right? But to be completely fair, if you were to talk to my clinic staff, my orthopedic admin staff, my partners, my residents, the people I work with every day, they'll tell you that I'm exceptionally reasonable. I always listen. And, in the operating room, I teach how to create an environment that everybody's safe to speak. Like I have an x-ray tech who for now, like 5 years has been basically, one of our main x-ray techs in the room a lot. Fantastic guy, very, very bright. And, I remember a specific case, and I tell this story to other resident places when I go there, but we're doing a plateau, and I had put in the apex screw long to push the plate down, right, purposefully. So sticking about 5, 6 millimeters out the other side medially. And, we've just disimpacted and we've got everything set up and we're putting in a screw up to the eminence and, we're focused in on the fluoro of the joint and it looks perfect. I'm like, okay, that looks really good. And, then I start talking to the resident, all right, let's get some Vanco paste, blah, blah, blah. And my x-ray tech says, hey, Dr. T, is that screw still a little long? And it was, right at the bottom of the fluoro, right? It was the one that I put in long that I normally automatically change. But, I was so focused on the joint, totally forgot, right? Nobody's perfect. But I was like, oh my God, Igor, thanks so much. Cause I was just about to like say, okay, let's start closing. And I wasn't planning on getting more x-rays. And now that I had looked at it and I had in my head checked it off, everything's good. I don't think I would have seen it even on that x-ray. So had it not been for him, the patient, potentially would have had a long screw. I mean, I don't know
Yeah.
if someone else would have picked it up or I would have picked it up, but I can't say for sure we would have. But that environment in the operating room of everybody feeling comfortable saying anything or asking anything on behalf of the patient, as you said, is absolutely critical. And I think you would hear that from everybody that I work with regularly. On the other hand, there are people in my hospital who think I'm a bad guy because I go overboard on complaining about why is CPD bad. I tell people when they're not doing a good job at middle level administration. So, I'm probably one of the favorites of the people who work hard. And I am not perceived that way for sure, not perceived that way by everybody at the mid-level. And that's something you have to decide. Like, you have to decide, are you going to be the advocate for patients? And does it matter enough to put yourself semi at risk? If you encounter people who are not going to do it for the right reasons, like what is the next step? And
Yeah.
that's a really hard political position. So for many, many years, I would enlist people above them. But when those people above them are not making it happen, right? Then at some point you have to take the patient advocate position and you have to push the envelope and continually tell people like it's not okay. And why can we not do this? Why is this happening? I need a written explanation. That's one of the things that really bothers people when I say I would like a written explanation back as to why X, Y, or Z. And people get very offended when you become very, let's just say persistent. Like you can never raise your voice, you can't curse, those types of things are not going to work. But persistence and continually questioning and continually staying on something makes people very uncomfortable when they're not competent.
Yeah.
So, that is definitely something I still have with those individuals. But I would say if you're a competent and good at your job, you probably love me.
Yeah, I find that fascinating, right? It's like our persistence is probably the enemy of mediocrity, because someone that's in a high stakes position like yourself that has the highest goals for patient care, I find that that tends to be like a flashlight on processes that aren't working successfully or processes that need to be improved. Talk to me a little bit about that. I mean, in the operating room, your processes, my guess, are probably as close to perfect or not perfect, but well done because you have that control, right? When you're in the operating room, that's you.
Yeah, I think when you're in the operating room, you have a lot more control, and we have a lot of we're an indigent care hospital. We don't have a lot of resources. So you do have to take that into account with what can happen, right? But there are certain things that you can't compromise on, sterility, equipment, things like that you can't compromise on those types of things. And I would say that, even when inexperienced people are in my room, like a new scrub tech comes in, like I was on call 2 weekends ago. I had someone who I had seen around, but I didn't know him. So I said, do you know this equipment? Now it's kind of funny because I used to ask people, do you know this equipment? And the reason I ask is because if they don't know it, then I'm going to scrub in and like help them and set it up and tell them this is what I call this. This is what I'm, like I do some pre work. But I never used to tell people that was why I was asking. So I certainly insulted some people early on by saying, "Do you know the equipment?" They're like, "Well, yes, I know the equipment." And then I'll say, "Well, did you ever work with this specific equipment?" "Well, no." "Okay, well then you don't know the equipment, right?" So just because you know how to fix a fracture doesn't mean you know the specific set, right? Because there's some differences. So now I've gone probably about 8 or 9 years ago. I figured that one out. I'm a little slow sometimes, and now I say, "Hey, do you know this specific equipment? Because if you do and you're rock solid, great. If you're not, though, I'm going to scrub in early and just kind of show you some things. So what do you think?" And most people take that the way I intended, right? And so, he said, "Oh yeah, sure, come on and show me what you want." And I did a bunch of cases over the weekend. He was with me both days, and at the end of it, he said, "Hey, thanks for showing me stuff." It was really nice to him. We had a great relationship, and that's the way you have to really make things work in the operating room. Like if someone's not good at what they're doing because they're a novice or new, you've got to bring them up, right? So I think those things, like you said, are completely controllable. The things that are not in our control are, how the administration over central processing, like how are they doing their jobs? Like what does their stuff look like? If there are errors, how do they correct it? What are they doing to track it? You know, if room turnover time is delayed, so now you've got, occasionally, and we still have it, patients who get canceled at 4 or 5 in the afternoon. So they've been
Yeah.
NPO all day. It's just terrible for patient care. And mid-level administrative folks and people in the operating room tend to think that the surgeon's fighting for themselves. Like, well, I want my case to go earlier. I want I. And when I say to people, like, is there any way we can get this person done? They'll say, okay, we'll try to help you out. And I always correct them and say, it's not for me. You're helping the
Yeah.
patient out. Like, if you say no, I go home. Like, I'm okay going home, right? Like, I like my house. I'm willing to stay because it's the right thing for the patient. And that's the goal, right? Like you want to always focus it back on the patient because more and more folks in the operating room don't see it that way. They see because you're the interface, represent the patient, but they just see your face saying, "I want to get this in," or "Can we do this?" or "What can we do to accomplish this?" But they're thinking they're doing it for you because that's kind of how it works. And you always have to reframe it around the patient.
Yeah. Yeah, that's a very interesting concept that honestly I don't think a lot of folks outside of medicine understand. That particularly as a surgeon, more than any other type of doctor, you are the interface. You are really the first line of defense for your patient. But I get this all the time on peer to peers. For those who don't know, insurance companies are increasingly asking us to justify the value of our care or the need for a procedure. I'm having an obstetrician deny an orthopedic procedure, saying that the quote unquote care is not needed. And I mean, truth be told, I get heated oftentimes on these calls because in the back of my mind, I have a patient who's failed a primary surgery, who's living through 9 out of 10 pain, unable to even get their child to school with a 20-minute ride. And here I have some doctor who's never even been inside of an orthopedic operating room say, no, your patient can't have that procedure. And so, yeah, I mean, I totally understand the passion, right? When you're advocating for your patient. What is it about your career? Like when did you notice that starting to happen? Like when, has it been throughout all of medicine? Like when did that advocacy come into play for you?
I think it for me, it came in as a resident. We were at a place where the residents had, at that time in training, quite a lot of freedom. Wasn't abnormal to be operating without faculty. And I think it sort of pushed residents into one of two things. One, they took on more responsibility, and I would say probably three-quarters of us did that. And then 25% just looked at it and said, "This isn't my problem." And they were a different breed. But I was in the majority, which was, we took more weight of patient care on ourselves, and we would have to advocate to get things done that needed to happen. Even as a resident, I remember I had a patient that when I was like a 4, I did an open tibia, and he got needed a flap, and didn't we didn't have plastics that could do flaps, and, we did our own local flaps, but he needed kind of a, more sophisticated than we could provide. And he ended up going to a very, very fancy hospital. He's a wealthy guy. He had gotten hit by a car or something, came to Kings County where I was. And he left and went, his family with the mink coat came in, and he briskly went to a very fancy place in New York. And he got his flap, and they did a good job. Everything went well. But then he was really slow to heal. And this guy shows back up in my clinic, like, 6 or 8 months later, asking for me because he didn't trust the fancy doctors in the city. He wanted the guy who was in the trauma bay with him, like explaining everything and going through things because, we had developed that relationship in the 5 days he was there, that he knew I cared and would look out for him and came back for that reason to, really arguably a terrible place. And I ended up treating him into the point where I was in attending. But that was sort of the way that things worked. You were the interface. You were the person that the patient saw and knew. And right now, I think residents, unfortunately, it's harder for them to develop that same ownership given the way that they're trained, like not through fault of theirs, but because of training. And I try to demonstrate that to them. I try to explain to them, like, you should own the patient. And I think in our program, our residents do way better than the average because I have some unbelievably strong partners. Nate Oshevsky, who's our newest addition, who was one of our residents I trained and came back. Mike Kane, who also trained with me and came back. And my partner, Bill Creevy, who's been with me since 98. As a trauma service, I think that they know they can call us 24/7. They see that we'll do anything that's necessary for a patient. And I think that they then want to follow in those same steps and really own the patients and get to know them better. And we hope that, again, that modeling maybe helps a little bit. But I think it's harder for residents now. And if you look at what the RRC is putting value in, I would say that they have made a left turn where they should have made a right. And,
Yeah.
I am someone who's pretty critical of things I don't like. So, I'll be really straightforward on these new case minimums, which I think are disastrously bad. Had multiple conversations with people at the RRC about it just as one program director. But, I'm not sure how many crackout stitches you need to be able to place to be able to do a second one. Like if you're not able to do it after the first one, there's probably something wrong with your mind or your hands. And what's happening is by increasing the case minimums to what I consider to be a very large number and keeping it as very basic cases, it's forcing program directors to do some bad things. Like one, pull people out of clinic to go get their numbers.
Yeah.
And two, to do yet another ankle or yet another wrist instead of doing an acetabulum fracture or a complex revision case. So it's really skewing training in a bad direction. And, if you look at how you learn and, Steve, you would get the answer right. But I'll tell you, like my residents tell me, "Oh, I'm looking at these jobs like, they want me to come to the OR. What should I do?" The universal answer I give them is go spend a day in clinic. Right. And you watch a physician in clinic, you see what's their relationship like with their patients? Do they care? And honestly, every important thing I've learned about patient care has been in clinic because I did X, Y, or Z and it didn't work the way I expected. Like the x-ray looked good. Everything did what I wanted it to mechanically, but this patient had some problem. Right? And then you have to figure out, well, why is that? What's
Yeah.
happening to this person? Because ultimately it's not for a trauma surgeon, not the x-ray. For a joint surgeon, it's not the position of the implant. It's how is the patient doing? And I think as a society, that's what our patients want. Our patients want a good outcome from their perspective, not a good outcome from our perspective. And so, the idea that spending more time in the operating room is going to make you a better doctor, I think is counterintuitive to anybody who's a layperson and anyone who really takes care of patients on a regular basis. Clinic time is the most valuable time. You learn the most. You learn to develop relationships, empathy. You understand why you're doing it. It centers you. I always tell my residents, like, the way you judge clinic is by number of hugs.
Yeah.
And that's actually what matters in what we do.
Yeah. Number of hugs, Christmas cards, you know, that 100%, right? How could you want to do anything else? And I think that's a very foreign concept, right? For listeners who are not in medicine to understand that you have a perfect x-ray, right? You leave the OR and it's high fives all around. And meanwhile, a patient can show up and they're not doing well. And, I frequently caution anyone, any younger doc who's thinking about getting more efficient by having their PAs see their post ops. Listen, you got this, orthopedics is a test. You got to check your answers. And when you don't check your answers, talk a little bit about that.
Yeah, I agree 100% with that, and I would say, I've been a chair now since 2017 because of my academy role. I sort of slowed down, so for the first time in my career over the last year or so, I've had a PA who will, like, see a wound and then, but they examine them, text me, here's what's happening. What do you want me to do? But that's only because I've slowed down a little bit on the clinical side. Like when I was operating 3 to 4 days a week and having a full clinic a week, I didn't let anybody else see my patients. I didn't want anybody else to see my patients. I wanted to see them. I wanted to know what's going on. I felt like I'm the one who was there. I know the most about the situation and no one else is going to be able to do that. And I think that younger physicians, when they go through their fellowship, because, as you know, every resident now goes on and does a fellowship. That wasn't the case when I finished. People didn't do that. And I mean, I didn't do a trauma fellowship. I did a few months with Joel Matta to learn better how to do acetabular fractures, but my general trauma stuff, I didn't train specifically for that. That just evolved.
Yeah.
Um, and they're in a fellowship where they're working with someone who has done all of that and seen their 15, 20, 30,000 patients, right, over the course of years and years. And now they have a system where their PA knows what they're to look for and sees their post-op patient, once, and they see them less often. But that system came about from someone who did all of the work. And then you come out of fellowship saying, well, the system should be, I shouldn't have to do this. I shouldn't have to do that. And really, it's you should want to do those things.
Yeah. Yeah.
And you're right. And what people see in fellowship is not representative of what they have when they start practice.
Completely, yeah. Yeah, I really enjoyed your story about, asking the techs, "Hey, do you know this?" And the reason being so that you can scrub it and show them if they don't. As a resident, a chief resident, I used to pick a couple days out of the year where I held the trauma pager and did primary consults because my goal was to prove to the residents that no matter where I am in my level of training, at any point I could go back to the previous level and still be successful. I think leading by example specifically is something that you seem to be pretty good at.
Well, I try to be. You'd have to ask the people who I'm working with if I'm hitting the mark. But I think you do have to lead by example. And the concept of shifts. I don't know. You see this when residents are applying. 15, 10, even 10 years ago, you didn't see a resident candidate write the word shift in a personal statement. And when I see it, I just vomit in my mouth a little bit, right? Because when you're an actual attending physician responsible for someone else's care, you don't have a shift, right? Your phone's on 24/7. If something happens to a patient of yours, you expect and should want a phone call about it so that you can be the one directly involved with helping to resolve whatever issue has occurred. And my phone is still on 24/7. My residents are told multiple times a year, like, the threshold for making a mistake is 0. You're not allowed to actually make a mistake. Like, you should hold yourself 100% accountable that every decision is accurate, because in the end, if the 2 isn't 100% sure, they should ask the 3. If the 3 isn't 100% sure, they should ask the 5. If the 5 isn't 100% sure, they should call the attending. And if that attending isn't 100% sure, they should get help, right? But ultimately, the most knowledgeable person in your system or among your friend group should be the only person able to make a mistake, right? And everybody will. But ultimately, if it's a trauma patient, my residents will call my junior faculty, they'll call me, at 2 in the morning. If a pelvis comes in and they don't know if, I think it will benefit from traction, I'm not sure. They call, they send the x-ray, they have to do it. They have to make a PowerPoint, send it by email and all these, HIPAA compliant things, but they get us a film. We look at it. They'll text or call one of us. We call back. Okay, let's
Yeah.
talk through it. Do this, do
Yeah.
that. Here's why, here's when, et cetera. And the patient gets what they should. And I do think that The idea of I just work these hours and I defer to other people for everything, it's not good. I honestly, the most common thing I say in morning conference is probably, if this were the person that you love most in the world, is what we did okay? You made this following decision based on information that was either inaccurate or insufficient because you didn't know enough about the topic. You didn't ask anybody. Now the patient is home and they have this. And if a PGY, let's just say two, at another hospital did this to your mother, father, spouse, child, would you be okay with it? And that's, I think, the way that we all have to think about every single thing that we do.
Yeah. Yeah, well, I mean, at its core, surgery has never been a shift specialty, and to be fair, in medicine, there are shift specialties. I mean, emergency medicine is, I think, the king of shift specialty, where it's zone defense and you're holding down the fort for 8, 12 hours, and then someone takes over and you leave.
And that's
But
appropriate, right? That's
yeah,
very appropriate. Anesthesia, urgency medicine, it is completely appropriate because they're doing a specific thing, but none of those people are ultimately responsible for those patients, except for in the environment they are at that time. We're ultimately responsible for the patient before their surgery, during their surgery, after their surgery, and for that problem for their lifetime, and probably for any orthopedic problem, for as long as they need help, we should be the point person.
yeah, I mean, that's well said, and that's what makes surgery different than really any other type of doctor, really any other type of profession. There is a spectrum of care which honestly can encompass an entire patient's life, especially in trauma, and that's I wanna hear a little bit more about that. So to set up the stage a little bit for the listeners, as a trauma orthopedic surgeon, you are meeting people at the toughest time in their lives. They've suffered some injury, that's changed the trajectory of their life. And so now Dr. Tornetta is on call. He is injected into that environment. And tell me what it's like to develop your chops as an excellent and compassionate trauma surgeon.
Yeah, I mean, I really think that it's not specifically different than any other interventional field. It's just that, we're encountering someone who maybe was semi-normal a minute ago, and now they're not, right? They have a brand new problem that's quite scary. Anxiety is really something that you have to learn to manage. And honestly, I mean, I'm not, just for the listeners, like I'm an attending surgeon. I'm not actually driving in to see an open tibia fracture in the emergency room unless someone calls me and say it's at risk. Like, that's not the most common thing. Mostly the residents see them early, and they need to develop those skills also from rounding with faculty and learning how to talk to people. But the number one thing someone wants to know is that someone is there and cares and is doing their best to help them. You can't tell people all the time, like, "Oh, it's gonna be okay," because that's just not true, right? There are things that are not okay, and that people will have to learn to manage with new deficits that they just had, right? They were normal a minute ago, and God forbid, now they're gonna lose their leg. That's not okay for anybody, but it's something they're gonna have to manage. So I think what matters to patients is that they see someone's face, they learn to recognize it, and that they can see in the way that they act and the way that they speak that they care. And that is the number one thing that a patient needs to feel in order for that anxiety level to come down, because they're a person too, and they know that when they care about something, they're trying really hard, right? If something matters to them, they're going to do their best. And inherently, you're sending that message. You don't have to say it. You don't have to say, we're going to do our very best. Talking about what's happened, what your plan is, that you deal with it, you know how to do it, the team is a good team. All of those are the messages that you send, that, you're in a place where this is what we do every day, and they know this is horrifying for you. It's not horrifying for us because we're used to it. We have a team that does this. We have people who do that. You're going to meet the following people. Like, just laying out the fact that there is a group of people, and not faceless people, but people who have specific responsibilities, who care about them, relieves anxiety, because that's all that they can cling to at that point in a tough spot.
Yeah.
So I think managing their anxiety is really, really good. I've had patients who will sort of start to cry or break down, or say, I'm really scared. And One of the things I say to them is I say, we've got a really good system for anxiety and fear. Okay. You can be as nervous as you want, and I am going to be completely calm. Almost every patient laughs at that, and it's kind of half a joke, but it sets the tone for saying it's okay for them to feel whatever they're feeling. Whatever is happening in their mind, it's fine, and I'm gonna be there to help. And that's
Yeah.
the message that you're trying to give them, right? You need to be with them. It's the same thing as the patient who has a complication, right? Everybody gets complications in their practice. And the thing you wanna do to make yourself feel better is just, never see that person again, right? If you never see them again, you can pretend it didn't happen and you feel a little better, and that's the opposite of what the patient needs, right? So when
Yeah.
you have someone with a complication, you've gotta double or triple down. You've gotta spend more time with them, you've gotta see them more often, and it's that same inherent message that you care and you're doing your very best. And ultimately, that's what everybody wants in their doctor. They want them
Yeah.
to be working hard on their behalf. They want them to actually care, and they want them to do their best. And
Yeah.
I think that every physician in training should take that lesson and just, begin right as a resident when they're in the emergency room. And I have countless residents who have done that. When we teach this, and I have just some fantastic people I've trained, some of which I've hired back because they're so good. But getting that right in the emergency room, right as a first or second year resident, learning to make the patient know that you care, right? That's the number one message, and I think that's
Yeah.
universal.
Yeah, I think it's fascinating, right? In medical school, we're taught all these techniques for, teach back and this, that, or the other about how to ways to kind of endear ourselves to patients. And, people will ask all the time, well, how are you such a caring doctor? Like, how do you appear like that or something? And the response is simple. It's not a show. I'm truly putting myself in this person's shoes. If you could just imagine for a fraction of a second, wow, what would it be like to actually have that? You can think of the right things to say because you can think of the questions you would have, right?
Right. That's exactly right. It's all about empathy. It's all about being, and for that reason, not everybody belongs in medicine. And, to that point, we do face some challenges in medicine because medical students run up a lot of debt. And it is, people think, well, you're going to be rich as an orthopedic surgeon. And to be fair, we do really well. I know that there are a lot of surgeons out there to complain, and it's a little bit one of my other pet peeves. And to be fair, I've done well, and I do some design work, and I'm not poor, and I'm very lucky. And, my speech at the academy last year was called Gratitude. And really what I discussed is my first speech as first president was what's good for patients is good for us. And I think that's the basis of our profession. My second speech was gratitude, and I think that's the thing that we all have to have. And, I hear, on the travels I had last year, I heard people complaining about, "Oh, we're getting killed. We can't make a living," and so I started a few meetings that I was at when I was giving updates and said, "Well, how many people in the audience have a vacation home?" And, like, more than 2/3 of the audience, typically not the residents, but the faculty, well, they have a second home. And I'm thinking to myself, well, let's not talk about financial difficulty then, right? Because I'm taking care of people who are making a decision as to whether they're going to lose their apartment if they don't have surgery to get back to work 2 weeks sooner. Like, I have many, many patients, in my environment. I have many, many immigrant patients. I have patients who don't speak English. But I have a lot of really hardworking people who, they don't do the job that I do, but I think there's a fair number who work as hard as I do, and they don't have anywhere near what I have in life. And, I think if as a surgeon and a physician, you don't feel lucky to be able to provide care for other people and actually have financial security, there's something wrong with you. And for that reason, I look at the people who are pushing limits, and, we all know that not every doctor is great. But, one of my reasonably new soapboxes, maybe it's a 10-year soapbox, is it's a patient choice to have surgery. And that decision, the biggest decision we make with a patient is whether or not to have surgery. And it's not our decision. It's the patient's decision. And our job is we're the coach.
Yeah.
And I do see places where people push the limits of doing something. um, and I think that I've seen a fair number of people, more than I'd like, just kind of go off the rails with being over aggressive with surgery where it's not necessary, and where it's not data driven. people convince themselves, well, they're helping the patient, but those are the people, right, who are not necessarily putting themselves in the patient's shoes, thinking about the complications, having that full discussion with the person. We as surgeons need to police that. The ABOS is our arm to police that. I think they do a pretty good job of looking for problems, but we do less well after someone's board certified than before.
Yeah.
It's important. It's important for all of us to hold each other accountable.
Yeah, I agree. It seems to be like our step two is this like magnificent experience where in some ways we're almost exonerated from following that, from having our work truly checked, which is probably not ideal. But I do want to explore this concept of shared decision making because some of the listeners may not be experienced with that. I think that should be a soapbox you should be on, hopefully, for the rest of your life. But what is shared decision making, and why is that different than the way that orthopedic surgeons previously indicated people's for surgery?
Yeah, that's a great question. So there's actually a fair amount of data in this too. It's not just a touchy feely. This is what you think, but shared decision making is pretty simple. It just means that you as a physician are providing information to the patient and that they're going to choose the treatment they want based on the risks and benefits of the options you have to offer. And there's actually a good amount of data about it that it does help actually outcomes. So, there was an interesting study that was done looking at carpal tunnel syndrome and consent process. So carpal tunnel syndrome for the non-medical people is just you have compression of a nerve around your wrist. It's compressed because it's inside of a tunnel. And the surgery is to sort of make an incision in the tunnel to open it up so the pressure is relieved. And really, you would anticipate that kind of surgery for the proper indication, like for the right reason, when someone has the appropriate symptoms and that would warrant it, would have a very similar outcome irrespective of what the consent process was, right? And there was a paper that showed that people's outcome, their actual outcome differed based on how the consent process went compared to the way they wanted it. So in other words, I have some older people that are very trusting of physicians who will just say, I don't want to know, I start to go into here's what can happen bad. And I don't want to know about it, doc. Now, for me, a lot of what I do is really not difficult decision making. If you've got a broken femur/thigh bone, that needs to be fixed. That's a pretty straightforward thing. No rational person would say no. So that's different than like a non-union practice where you're discussing, for an open tibia that's not united. I go through everything. Do you want to use a bone stimulator, dynamization, exchange nail, bone graft, exchange nail, bone graft, right? And if you want bone graft, what do you want? Like that's 6 different options. It's like a menu. 3 visits to explain it, to re-explain it, to answer all the questions, to tell them to look it up and come back with questions. Like it's not such an easy thing because there's real risks and benefits for each one. And there are people who say, I'll take the risk. And then when someone says, oh, I'll take the risk, you have to explain what it is again, right? Because you say, well, there's a risk of infection. And people will stop there. And then patients who are aggressive and want a good outcome, they're going to say, well, I'm willing to take that risk, but they don't really understand it. So, as a coach, you have to sort of titrate that and say, if they really aggressively want a big surgery, you have to highlight the risk. If they really want no surgery, you have to highlight the benefit. But you basically have to get everybody about to the middle ground where they're really thinking about both sides before they can make an educated decision that's best for them. So when someone really wants surgery, for their tibia that I think I wouldn't, if it were me, I wouldn't necessarily do the big surgery. Maybe I'd do a dynamization or a small surgery with low risk. I tell them, well, let's just talk about the downside of that. So because if it works, great. But there's a small percentage of people going to have an infection. So let me just go through what that is. And then I explain like there's going to be redness. There's going to be a gross infection. Pus will come out of your leg. At that point, we're going to have to take all the metal out, all the bone graft out, put you in. And I go through this extensive discussion that I don't even have time to go through with you because it's 20 minutes and scare the out of them and tell them that, at the end of that, there is a non-zero chance you lose your leg. Is it something I expect? No, but it's not zero. And that resets them to the middle ground, right? So they see the benefits already. Now they're starting to see the risks. Then that has to percolate.
Yeah.
That's a shock, right? Because their personality is not that. They think go, 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 go. You have to have them back again a week or two later and have that same discussion again now that you've reset their framework. And the same thing goes with someone who's watching something that is not going to go well unless you intervene, right? You've got someone, it's screws are starting to loosen. You know something has to happen, something's bad, and they're like, "Well, just leave it alone, won't it get better?" So they're in denial, and you've gotta highlight the risks of leaving it alone for them to reframe them somewhere near the middle, and that's really the hard part of our job is to understand where someone is philosophically and get them to the point where they see both the risk and benefit side in a rational and logical way. And then whatever decision they make, that's what I'm going to do. I've had people, many people pick the option I would not have picked. Like I've had people pick a more aggressive option and a least aggressive option than what I think I would pick for myself if I was in that position. But as long as you feel very comfortable that the patient really understands, that person in front of you really understands what they're signing up for and is accepting the risks and benefits and has a logical reason for doing so, then you go ahead and you do what they want as long as
Yeah.
it's reasonable. So when you offer five reasonable options, you do what they want. And that's shared decision making. It's them deciding for themselves what's the worst thing that can happen, what's the best thing that can happen, how does that affect my life, what kind of support do I have at home, how will that affect my employment? Will I be able to pay my mortgage? All of those things are different for every person. And really, that is the basis of shared decision making.
Yeah. Yeah. I mean, you've just said so many tremendous things there. It's almost impossible to unpack it all. But I guess what I would distill it down to is like coaching, right? As orthopedic surgeons, I think folks assume, especially when they've ascended to the level that you have, like okay, I know what's right. I'm going to tell you the secret sauce of what's right. You're going to do it. You're going to have this A plus outcome. That's not at all the case.
Yeah, and I have people sent in to me that way too. So, one of the other challenges is convincing people they don't need surgery, which is really an interesting problem, right? Someone gets sent in for some X-ray finding that says, something's not united, right? And they come in and they're referred in and say, "Oh, how are you? I'm Dr. Tornetta. What are you here for?" And they tell me, "Well, my bone isn't healed." I said, "Okay, let's go back a step. Forgetting about what anybody else told you, what problems are you having?" That's what I revert to. And I have to say that pretty often with referral patients because they come in being told, like I have clavicle fractures, I was sent here for surgery. And I have to reframe that and say, well, that may have been true, but really what you're being sent for is for me to discuss surgery with you because the person who sent you doesn't do a lot of it. It's all I do. So really you're being sent for a higher level discussion. So let's forget about, you think you need surgery. Let's talk about what that would be. What are the pros and cons? What are the statistics on each side? And then you have a discussion. And, the people who are sent in for surgery who you really think they don't need it or there's not, the risk benefit is on the wrong side, more risk than benefit, which happens, a fair amount to me because I'm conservative. I have to tell them, look, I'm telling you, you don't need surgery, but just to frame it so you understand, like I pay my mortgage by doing surgery. So if I tell you you don't need it, there's probably a good reason for that because somehow there are people who think, well, you're being biased against them or you don't like them. So you don't want to help them or whatever because they were predisposed to saying, I got sent in for surgery. And then this doctor who's supposedly an expert won't help me. And, that discussion is a tough one also. So it's all about that coaching. It takes a lot of time and it takes being a listener and an empathetic person.
Yeah. Yeah. I mean, in the conversation, we probably could have filled an hour of just talking about the technicals of trauma surgery and everything knowledge you've amassed about that. But I find it way more gratifying that we've sat here and talk about building a career around having yourself as a patient advocate. Because to be honest with you, I completely agree with you. I think that's what younger doctors are missing in training. And that's the thing that scares me the most about our profession, which is arguably, medicine, the most noble ownership really is ownership, is to say, listen, when no one else has the answers, will you be the person showing up at 2 a.m. doing the work to have the answers? And if you can answer yes to that, then you can be a successful surgeon.
I agree, and I've done a lot of things in my career. None of them were really by design, right? The things that I happened into were always based on either a deficit I felt as a resident. Like when I was a resident, Rockwood and Green was my Bible. We didn't have lectures at my place. I read that book cover to cover so many times I can't even tell you. And the in-training exam was very important to me because it gave me feedback on depth of knowledge. And at one point, one of my friends, Vin Sandu, is a resident with me. He's at HSS in spine, so maybe the opposite of a indigent care trauma surgeon, but real good guy, and we were the same year, and we used to joke that one day, I'd be a chairman at some at some county hospital, and he'd be at some and it turned out that way because that was sort of our personality. And I, at those times as a resident, thought, I really think the in training exam and that feedback one gets about their knowledge is critically important. And I thought Rockwood and Green was the best book in the world. And the only two things I wanted to do in my career as a resident were to run the in training exam and be involved with Rockwood. And it happened to do that. I got invested in questions and testing, and I ended up running the in training exam, and I ended up being one of the editors of Rockwood. And well, those are all, it just shows you that, what you experience in your youth as a surgeon, it stays with you. Those things, those habits, the things that you find important as a resident are things that will always be important to you. And I look at my residents now and I can sort of say, well, this one's going to be really good in advocacy. They're mature, much more mature than I was. They recognize that a healthcare systems issue is something that can be solved. This one is really going to be a great patient advocate. I can see this one doing a lot of research because they have a lot of questions. Like, you can see what's important to people. And not every surgeon is the same, and not every career is the same. And in your career, Steve, I'm sure you'll do great things. And I've done some things I'm very proud of, but every single one of those things was based on something that was important to me for patients, right? Like, I've gone the educational track and a little bit the leadership track, but really the educational track was always my passion because I feel like education is the one thing that every surgeon has in common. And if we can all work on educating ourselves and everybody else, that's how patient care improves. And ultimately, that's what it's all about, right? Design work. I started designing implants because I hated some of the stuff was around, not because I said, oh, this is a great opportunity. I would do it for free. I just said, why can't we just have something that does this? And so I think that, if you continually in your career strive to do better for patients, you'll have a lot of opportunities outside of just your own clinic and operative volume and patient care opportunities, right? You'll do those things. You'll be an advocate. You'll do well, but other things will come your way. Like, I didn't desire to do a lot of the things that I ended up doing. They came my way because of passion about something else that typically someone else, like Roy Sanders put me on my first committee. Right. And because he saw something in me and said, this kid's got passion. Like, he really gives it. And he, I think I reminded him to some degree of someone who was like just a little younger than him, but he had the same fire. And so he gave me an opportunity. And when you get an opportunity and you knock it out of the park, you get another opportunity, and other people recognize what you're capable of. Getting ahead in that way, I think, is the way that's good to get ahead. I see now people getting ahead by self-promotion, and that's another thing that makes me want to vomit in my mouth, right? When someone gets on and they make their video about, the most recent one is people commenting on an athlete's injury for which they know nothing about. Everybody wants to have their moment in the sun and self-promote themselves, and all of. So I don't have social media, as you would guess, because I would just vomit all the time. But, people send me stuff like, oh, I'm so privileged to be part of. Okay, that's just saying me, right? Oh, I'm going to teach you in a minute about this little problem on social media. Me. The people who are really special are the ones that get ahead because someone else recognizes what they're doing, not
Yeah.
from self-promotion. It's almost diametrically opposed that the bigger your social media presence, if you're a me person, the less your actual skill and ethics.
Yeah.
Now, there are some people who do it well. There are some people who educate on social media. So I'm not saying all of it is bad. There's a lot that can be gained from that, particularly internationally. But I think probably everybody who's listening, knows the types of people I'm talking about. And it's just a bad thing.
So you said one thing that I thought like was awesome. If I had a gravestone one day, I'll put it on my gravestone, which is to understand a person's action, consider their motivation. It's a profound comment, but to that effect, right? I want to ask you one pointed question, which is, you've had a successful career. Lots of folks are young docs are looking to accomplish even a quarter of the things that you've done. So, like, if you could go back to yourself as a younger resident or a younger doc or whatever and give yourself one piece of advice, What piece of advice would you give knowing what you know now?
Do what's important to you, because that's what I did. Like that is the genesis of, I think, most, and having a successful career. Let's be fair about that, right? Just I happen to be really interested in research and teaching, as a way of patient advocacy, because that's what I was passionate about. I love to teach. I love to learn. I like to get answers based on the way I was raised. So those things were important to me, and they were the things that I did were recognized by others, and I was giving opportunities to lead. And when you're leading, you need to walk out in front. You need to have to lead by example, as you said, and you need to provide a compelling reason for the direction you're going, because people don't have to follow you. Right. And I think that there are many, many, I have met a lot of leaders throughout my experience that whose names you wouldn't know, who are every bit as effective as I am in what they do, but they do it on a different scale. Maybe they're interested in advocacy for patient choice. Maybe they're interested in bolstering, their state society to make an environment better for the surgeons in their area, to have a community when they're in private practice. I think that there are so many ways to excel, and doing research and giving good lectures and things like that. It's one way, but it's not better or more valuable than what many other people who I know, whose names you wouldn't know, are also doing in their communities and for their patients and within their systems. So I think my advice to residents is, I never aspired to be the president of anything. Like, I never even thought about that. We joked as residents about being the chair somewhere, but really it was just a matter of, we wanted to make things better in these different places. What I always wanted to do is take care of people. And my career is just a natural outgrowth of that single desire. Being involved with making implants was because I didn't like what we had, and I happened to be lucky enough to have some biomechanical innate understanding, and can sort of figure stuff out. I think there are lots of people who can do that, not just me, right? So I think that for the residents listening, it's what matters to you is what you should do, right? Like, the quote success that I have is right for me because it's in the areas that matter to me. But if my areas that matter to me were more around, I don't know, systems issues or health policy, my career would have gone a completely different way. That wasn't where, my specific, let's just say that my goals to talent match, right? My goals to talent match were in logical thinking. When I was a kid, everybody said I was going to be a lawyer because I argued about everything. Um, I'm a very logical thinker, and that's what comes easily to me. So it's more fun to do stuff that comes easily to you. If I were to try to be on the advocacy side, I would always feel like, well, I'm kind of arguing for money, and the people who do it well argue because they understand that it's access, right? So if you do what's near and dear to your heart, your career will unfold in the direction that it should, to make you successful and happy. My success is not what other people's success should look like, because it was right for me. And this is like shared decision for a career, right? It's the same exact thing. Like, what's the risk and benefit of doing research? Well, you pound your head against the wall a lot. It's really, really hard. And if you don't strive for answers and want to die for them, there's no way you can keep doing that and be happy, right? You have to really want to understand things to be, to engage in that in a realistic way, nights and weekends, right?
Yeah.
And it's the same thing for any other direction that someone might pick. Like, I know people they've gone to business school and their success is in developing a multi-specialty group that provides high level care. Again, it's patient centered, it's high level care, right? If the goal is to make a lot of money, that's terrible. That's not going to get you places. So to me, the advice is, if you're in medicine for the right reasons, patient care matters to you, and you will feel innately the areas in which you are passionate, and you should follow those through, and you will have a very successful and happy career where you look at yourself at the end of the day and you feel really good about what you're doing. And that's what real success is. It's not
Yeah.
having someone know your name.
Yeah. I mean, it's awesome to hear. I mean, we've kind of come full circle now from, you looking on, docs like Dr. Sanders and having that high level of respect, but not because you wanted the podium position, quote unquote, because you wanted to carry that weight for your patients just like he did. And that was something that made you passionate. I totally agree. I think in medicine and in life, I think all of us are one piece of a very complex puzzle. No piece is more important than the other piece. Without each one of those pieces, the puzzle doesn't exist. So the humility for someone like yourself to say that, I think is profound, and I think people should just focus on being the best version of themselves that they could be.
And work hard, right? Like I will honestly tell you, like I was the last person accepted to probably the worst residency in the country. And if you were to bet on anybody successfully doing research or having any kind of leadership role, I would have been the dark horse that would have made you retire if you bet a dollar. So, it's not where you come from. So for all the residents, the students who are, they're not excelling in whatever they're doing for whatever reason, if you're passionate about what you do, and you're willing to put the work in, success will come in the way it should. I look at myself and I say I think I probably spent more hours reading as a resident than any resident my year in the country. I think I spent more hours working than most people. So I'm not smarter, but I did work harder. And I
Yeah.
think that's available. That amount of effort is available to anybody. It doesn't matter how smart you are. I'm not as smart as Roy, but I probably outworked him a little bit to get anywhere where he is.
That's awesome. Well, I mean, you're certainly echoing the message that now I think I've heard throughout most episodes of this show, not surprisingly, which is the first thing that you need to do is show up, be present, and work your hardest. And if someone asks you to do something, you show up and you do it to the best of your ability. And that's very clear to me that you've gotten where you are through hard work, blood, sweat, and tears, not a silver spoon.
Yeah. And it's always remember it's not about you. It's about
Yeah.
somebody else.
Cool. Dr. Tornetta, thank you so much for being on the show. This was an amazing experience just getting to pick your brain. But now you get to pick which brain that we get to pick next. So without further ado, who do you think you'll select?
Well, I think